Good evening, friends. Greetings from the Global Academy of Medical Education. I am Dr. Vaibhav Seth. I am the Faculty of Medicine at GAME. So, yesterday, guys, have given the FMGE examination. So, what are the reviews that I have got is that the paper 2 was on the tougher side. So, never mind. I have tried to collect different questions that have come in the exam based on the recall from my students and the online sources. So I am here to discuss the questions that have come in the exam. I have collected around 25 to 26 questions related to medicine. And the disclaimer is that since it is based on the recall, so there might be some discrepancy between the language that you have got in the exam and the language that I have presented here, plus the options may be plus minus. So if you feel that in any question there is a discrepancy or you had some other question in your exam, please feel free to comment in the comment box below. Right, I have tried to cover the questions that have come. Along with that, I'll give you the explanation. And it is important for those who are preparing for NEET PG to go through these recall sessions, because the same body is conducting both the exam. So you might get a repeat of these questions, right? And as far as medicine is concerned, the topics that have been given in the exam mostly were some of the topics that are repeated, like JVP, Gout. These are some repeat topics, so you cannot afford to miss them in your exam. So without wasting further any time, let's start with the questions that have come. So the first question was on JVP. That the question was, giant V waves are seen in. So there is no other answer, but the answer is mostly tricuspid regurgitation. There should not be any controversy to this question, right? You do not get in MR, you do not get in aortic regurgitation, you do not get in mitral stenosis. So if you see that I have drawn a waveform of JVP here, I have drawn here. It has got A wave, it has got C, it has got X descent, it has got Y descent, and it has got a V wave. In tricuspid regurgitation, what you get is giant V waves. You get giant V waves. They are also called as CV waves. It is said that in tricuspid regurgitation, the waves can be ventricularized. Right? So the answer to this question is tricuspid regurgitation. There is only one answer to this. Second, rise in JVP with inspiration. This is nothing but Kussmaul sign. Normally, JVP should fall by around 3 centimeter with inspiration. So if there is a failure to fall or rise, we call it Kussmaul sign. And it is classically seen in constrictive pericarditis. Now there can be some other causes also, like right ventricular infarction, advanced LV failure. These can be the other causes of Kussmaul sign. Okay. Moving to the next question. The question was asked, exudative pleural effusion is seen in. Now, all the three causes that have been mentioned here, all the three options that I have mentioned here are mostly transudative. They are causes of transudative pleural effusion. So anything that is beyond this, any option that would have been asked apart from this would have been your exudative pleural effusion, right? It is seen with infection, connective tissue disorder, malignancy, mesothelioma. All these are causes of exudative pleural effusion. Now to call it a exudative pleural effusion, we have a criteria known as a Light's criteria. When you aspirate the pleural fluid and send it for the study, right? So when you send it for the study and do the analysis, if any of the one of the criteria is fulfilled, if any one criteria is fulfilled of these three, then the pleural fluid is said to be exudative. It is said to be exudative, right? Next is the question was asked on the component of Q-SOFA score. The component of Q-SOFA score, right? The components are respiratory rate, SBP, and the GCS. Right? So if you have a score of 2 to 3, it suggests risk. It suggests increased risk of sepsis. So these were the components of Q-SOFA score that were asked. So you have to remember RSG, respiratory rate, systolic blood pressure, and the GCS, right? So anything that was out of these three options would be your answer, right? Then there was a question on cryptococcal meningitis, maybe a clinical case that was asked. So if you are asked a case of cryptococcal meningitis, there are certain prerequisites. The patient should be HIV positive. It's not that only you see cryptococcal in a immunocompromised patient. You can also see in immunocompetent patient, but that is rare scenario. For your exam point of view, cryptococcal meningitis, HIV patient, it should have a subacute presentation. It should have a subacute presentation. This is what differentiates it from the bacterial meningitis. It has a subacute presentation, right? And when you do a CSF analysis, you can identify E cells with the help of Indian ink presentation. With the help of Indian ink staining, you can identify, or you can identify with the help of cryptococcal antigen. Cryptococcal antigen can be done to diagnose cryptococcal meningitis with the help of CSF fluid, right? What will be the treatment? Treatment would be amphotericin B, flucytosine, and fluconazole. Right? And fluconazole. Okay. This question is a very common question that is asked, right? And so in the COVID pandemic, during the COVID pandemic, everyone was popping multivitamins. So the answer to this question is one of the multivitamins that presents with neuropathy, the excess of one of the multivitamins present with neuropathy, and that is B6. The excess of B6 presents with sensory ganglionopathy. Right? Now suppose if you do not have these options of multivitamins that are given here, this question can be modified in another way. They can give you some of the minerals in your option. So if you are given some of the minerals in your option, and especially if they are saying COVID pandemic, so in the COVID pandemic, everyone was popping vitamins containing zinc. So excess of zinc causes hypocupric myelopathy. It causes hypocupric myelopathy. So this question can be twisted in your exam in this way. For this question, if your options were given in the form of B6, B12 and other vitamins, B1 or vitamin D, your answer is B6 because excess of B6 causes peripheral neuropathy, right? But your option can be twisted in this way. When you have excess of zinc, you can have hypocupric myelopathy, right? Next is you were asked about the fecal-oral spread is seen in which type of hepatitis? It is seen in Hep A and Hep E. So in this option, your answer would be Hep A. Rest all have got sexually transmitted. They are sexually transmitted disease. They can also be transmitted by the blood route. Okay, but Hep A and Hep E have got fecal-oral spread. So Hep A is the answer here. Next, the question was asked on anti-basement membrane antibodies is seen in which condition? It is seen in the Goodpasture syndrome. It is seen in the Guillain-Barre syndrome, where you have involvement of lung and you have involvement of kidney at the same time. With lung, it presents with hemoptysis, and in kidney, it presents with hematuria. It presents with hematuria. The recognition of this condition is very important. It is one of the example of basement membrane disorder presenting with glomerulonephritis. So it's a pulmonary renal syndrome. Okay, pulmonary renal syndrome. You have to identify this condition very promptly because it needs aggressive management with immunosuppressants and plasmapheresis. Next question was HIV patient with CD4 count less than 100 and with pneumonia-like presentation with presence of AFB positive organism in sputum. Now students, here there are two confusion as to answer could be MAC or nocardia, as the answer can be MAC or nocardia. So let me clear your confusion, whatever your question would have been. The first important statement that is here is CD4 count less than 100. CD4 count less than 100. So for MAC, the CD4 count should be less than 50. For MAC, the CD4 count should be less than 50. So this is one of the pointer that CD4 count here is less than 100. And along with that, AFB positive organism, nocardia is weakly AFB positive. And what you can get is a branching structure. You can get a branching structure in the sputum. If you get a branching structure in the sputum, the answer would be nocardia. So 2 points here. One, presence of branching structure, and the other is CD4 count. MAC would have been preferred if the CD4 count is less than 50. So the answer to this question here would be nocardia. Next, this question is a repeat question. It was asked that a female developed wheezing after taking aspirin for headache. So this is one of the example of asthma that is exacerbated by use of NSAIDs. Previously, it was known as aspirin sensitive headache. Previously, it was called as a aspirin sensitive headache, but now the terminology has changed and the terminology is now asthma exacerbated respiratory disease. The terminology now is asthma exacerbated respiratory disease. And the question which is asked here is which of the following is true? So, as you know that there are two types of asthma that we see. One is the intrinsic and the other is the extrinsic, right? The extrinsic one is atopic. The extrinsic one is atopic and the intrinsic asthma is non-atopic. This is non-atopic. So atopic one is associated with increased in IgE levels. This is associated with increase in IgE levels. Here the IgE levels are mostly normal. So in this question, your answer would be nasal polyp. Your answer would be nasal polyp, as you can see that it is fulfilling the Samter triad. It is fulfilling the Samter triad. It is fulfilling the Samter triad, which you see there are 3 points in the Samter triad. One is the aspirin intolerance, development of asthma, and the presence of nasal polyps. So if you encounter any adult patient, especially females, with a history of bronchial asthma and presence of nasal polyps, you should be very cautious that these patients can develop aspirin sensitive asthma. They can develop aspirin sensitive asthma. And nasal polyp is one of the part of Samter's triad which you are seeing in this question. So what is asked here is which is true. So it is definitely not extrinsic asthma. It is not definitely increase in serum IgE. So from this knowledge, you can at least rule out two options. And nasal polyp, you know from the Samter's triad. Okay, you know from the Samter's triad. Next question was asked about cryptic TB. So what actually is cryptic TB? Cryptic, we know there is a term known as a cryptic miliary TB. This is the term known as a cryptic miliary TB. Now this is very notorious because this cannot be diagnosed. It is usually missed. Why? Because of its atypical presentation because of its atypical presentation, not only clinically, but also in the chest X-ray. Also in the chest X-ray and also in the terms of tuberculin skin test. This is basically a disseminated tuberculosis. This is basically a disseminated tuberculosis. So in such patients, normally you have a normal X-ray and you have a normal skin tuberculin test. That's why these patients are often missed and they have got a high mortality rate, right? So this was a very good question, and it involves this concept that the cryptic TB patients have got a normal chest X-ray and normal skin tuberculin test. You may say that the cryptic miliary word is used, so why the patient is not having a miliary modeling? Well, that's the part of the cryptic miliary TB patients, that they have a normal X-ray, right? Now, this image-based question was given where you have to answer what it is, right? So as you can say that there is a convex shaped hyperdensity. A convex shaped hyperdensity always goes in favor of EDH. And there is a arterial bleed in EDH. This was one of the questions that was asked in EMISET also. They had asked about subdural hematoma in that case, where you have a concavo-convex bleed, So EDH is by the arterial bleed, whereas the subdural hematoma is by the rupture of bridging veins. This causes subdural hematoma, right? Next question was asked about which of the following cause is the cause of unconjugated hyperbilirubinemia. So bilirubemia is basically conjugated and unconjugated. In conjugated, you have two syndrome. One is the Dubin-Johnson syndrome and other is the Rotor syndrome. And in unconjugated, you have Gilbert and Crigler-Nazar. So Crigler-Nazar was not given your answer. So the answer would be Gilbert, because Dubin-Johnson and Rotor is definitely not the answer. So your answer here would be Gilbert syndrome. Okay. Next question. You had an image-based question which showed you a KF ring or a sunflower cataract. So definitely with a case scenario, so definitely it's a case of Wilson's disease. Now you were asked which mineral is in excess here. So the mineral which is in excess here is copper. This is a autosomal recessive disease. Which has got GI as well as CNS manifestation. As you can see very clearly that this is the KF ring. You can see very beautifully that there is a KF ring, right? So KF ring. So answer here is copper. This is due to the deposition of copper. Okay. Next question was asked. A 5-year-old child with proteinuria and effacement of podocytes and is on corticosteroids. So the word effacement of podocytes with proteinuria, that means you have a case of nephrotic syndrome. Plus effacement on podocytes, plus there is effacement of podocytes. For this question, you do not have any other answer except for the fact that it is a case of minimal change disease. This is a case of minimal change disease. Okay. Next question. You had a question, a clinical based scenario. I think there were two questions on myasthenia gravis. So if you have a case of ptosis, which is showing a diurnal fluctuation, it goes in favor of a neuromuscular junction disorder. Now, neuromuscular junction disorder that is showing with improvement with neostigmine, which is a acetylcholinesterase inhibitor. definitely your answer would be myasthenia gravis. Definitely your answer would be myasthenia gravis, right? Now, another neuromuscular junction disorder is Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome. In such patients, you usually have a malignancy. You usually have a malignancy in the form of, say, small cell lung cancer, right? Small cell lung cancer. But that was not with the case that you got in your exam. It is clearly mentioned that the patient is showing improvement with neostigmine. So the answer here is myasthenia gravis. Next question. There were, I think, 2 to 3 questions on gout. So you have a 70-year-old elderly with severe knee pain, and analysis of the synovial fluid shows birefringent crystals, right? Now, if you had negative birefringent crystals, in your option, then your answer would be uric acid. Then it is a case of gout. But if you have positive birefringent crystal, then your answer would be pseudo-gout. That is the calcium pyrophosphate deposition disease, right? Although the most common joint that is involved in pseudo-gout is knee, but if they are giving in your option that what type of birefringent crystals you are seeing, then your answer would change accordingly. Because we all know that the most common joint that is involved in gout is the first MTP joint that we get classically, podagra. But you try to recollect what you got in your answer, in your exam. If it was a negative, then it is a sure shot case of gout. But if it is positive, then the answer would be pseudo gout, that is the CPPD, right? Okay. So next question was basically an integrated question of neurology with vasculitis. So you have a 60-year-old male, right? And you have a patient with unilateral throbbing headache. And you have tenderness in the scalp. So all these are basically the red flag sign. These are the red flag signs for headache. And you have to promptly consider that there must be a secondary headache. So age more than 55, a unilateral headache with tenderness in the scalp. What they are trying to show is that this patient is having tenderness in the region of temporal artery. So your answer would be giant cell arteritis. It is a large vessel vasculitis. The other name of it is also temporal arteritis. Okay. The treatment here would be corticosteroids. Okay. So defective gene in Duchenne muscular dystrophy, as you know that this is a X-linked disease. And you have the gene mutation of dystrophin. Right? You can get 2 type of disease here. One is the Duchenne and the other is the Becker's. Okay. So next question was treatment of choice for acromegaly, right? If this was your question, I actually could not get the actual options that were given for you in the exam. So just let's try to analyze what could be the answer. So if you have such a question where it is written treatment of choice for acromegaly, they're asking. So treatment of choice is usually surgery. The treatment of choice is basically surgery because such patients usually have underlying pituitary tumors. Okay. So if surgical approach was given in your option, then that would be the answer. But if they have not given the surgical approach and they are giving you different drugs, then accordingly your answer would change. So you can have either octreotide, lanreotide, or pegvisomant as your options, right? So if you have all three as your option, you have to go for an option that is long-acting preparation. The long-acting preparation would be your answer. The mechanism differs for all the drugs that I have said. Octreotide is mostly short-acting. It is mostly short-acting, whereas lanreotide is a longer-acting drug. So you try to give the depot preparation of these drugs, whereas pegvisomant is a GH receptor antagonist. It is a GF receptor antagonist. So if you are asked first line treatment for acromegaly, or if you are asked a treatment of choice for acromegaly, the answer is surgery. Okay. Next question was a 6-year-old child who is having hematuria with presence of RBC cast and proteinuria. So this is not nephrotic syndrome. This is basically a case of nephritic syndrome. This is basically a case of nephritic syndrome. This is basically a case of nephritic syndrome, and most common cause of nephritic syndrome is post-streptococcal glomerulonephritis. The most common cause is post-streptococcal glomerulonephritis. So that is the answer. You will not have MCD, minimal change disease, not membranoproliferative glomerulonephritis, neither nephrotic syndrome, because clearly they are saying that you have presence of RBC cast. So that is a case of nephritic syndrome. Okay. Next question. If you were asked a question on renin inhibitor, so you have basically angiotensinogen that is converted into angiotensin, and then you have angiotensin 1 and the angiotensin 2. So renin acts here. Renin acts here, and angiotensin converting enzyme, which is the ACE, they act here. So the answer would be different based on what you were asked. If you were asked about directly, if you were asked what is the direct renin inhibitor, then you have drugs like aliskiren. But if you are asked what is the drug that inhibits the conversion of angiotensin to angiotensin 2 or angiotensin 1, then the answer would be ACE inhibitor. Like enalapril, ramipril. All the prils that you have would fall into this option, right? Or if you have, then comes the receptor blockers. These act on the angiotensin receptor. Then you have the receptor blockers. So all the sartans will come here. So this was a question basically testing your knowledge on the renin-angiotensin system, RAS system. So based on all these three structures, anyone can be answered depending on what question you were asked. Then another question on gout. I think there were 3 questions on gout. So you have a 40-year-old male with gout, and the question is asked, what will you use to lower the uric acid level? So I think there were 2 questions from this side. One question was, how would you lower the level? And how would you increase the uric acid excretion? How would you increase the uric acid excretion? So increase of uric acid excretion means use of drugs known as the uricosuric drugs. So uricosuric drugs are basically probenecid. And benzbromine. And how you lower the level? You lower the level by use of xanthine oxidase inhibitors. Xanthine oxidase inhibitors are allopurinol and febuxostat. Now, since both are given in your option, allopurinol and febuxostat, which one would you choose? Allopurinol would be the answer, because this is the first drug of choice. To be used to lower the uric acid level. So we are having 2 type of question here. One is the preventive aspect. Let me make you very clear. When you are preventing, in the preventive attack of gout, you do not use colchicine. Because that is used in acute attack of gout. So this is definitely not your answer. So the confusion would arise between allopurinol and febuxostat, right? So it is clearly given in Harrison that the first drug of choice is always allopurinol, right? And febuxostat we use in patients who have got chronic kidney impairment or who have got certain HLA polymorphism like 05801, which causes the predisposition of allopurinol patients to Stevens-Johnson syndrome. So there are certain clear-cut contraindications to use of allopurinol where febuxostat is used, but the first drug of choice is always allopurinol. And if you are asked what is the drug that is used to excrete uric acid, that is the uricosuric drugs, so in that question your answer would be probenecid. So basically integrated pharmacology with clinics was such sort of a question. Next, you had a question on GB syndrome where they have given you a clinical case scenario, patient developing acute ascending paralysis with no sensory symptoms and minimal joint position sense involvement. So GB syndrome is basically a polyradiculopathy. It's a polyradiculopathy. So in that condition, it is basically what you get is a motor weakness. Motor weakness, you usually do not get any sensory involvement. Right? Except for the fact that you can get a minimal joint position sense involvement, which is basically the posterior column. Otherwise, you do not get the sensory involvement. And involvement of the bladder bowel is also not there in the GBS. The involvement of the bladder and bowel is also not there in GBS. If you get such an involvement, you have to think of the involvement of the spinal cord. Right? How you treat GBS patient? You treat with the help of IVIG. Next question, I think there was a question that has told you that there is a presence of ear vesicles. Along with that, you have developed a lower motor neuron facial palsy. Right? So that is basically a case of Ramsay Hunt syndrome. So ear vesicles plus the lower motor neuron facial palsy, it is a clear-cut case of Ramsay Hunt syndrome, right? In lower motor neuron facial palsy, the forehead also involved, and you get Bell's phenomenon. And the involvement is usually ipsilateral. So a next question was, this is also a very clear-cut question, which is telling you small joint pain, multiple small joint pain and the presence of morning stiffness. So small joint pain plus morning stiffness. So this is classically a inflammatory arthritis. And most common cause of inflammatory arthritis is rheumatoid arthritis. So the answer here would be rheumatoid arthritis, right? So this basically brings us to the end of the recall session, the recall questions that I could collect for the FMGE examination 2023. So if you have any other comments, or if you find that any question had discrepancy or there were some other options, any doubt, you can please write in the comment box below, and do subscribe the game in the YouTube and join our GAMEPGAPP app. Thank you.